Ayun, skip na.
Okay, so I hope you were able to locate the letters before I flash the answer. No? Why did I show you that slide? So in laparoscopic surgery, or what we call minimally invasive surgery, you are very dependent on what is shown to you on the video camera, the image in front of you. No? So you need to see everything. You need to see even the minor details that are presented in the screen, because if you happen to if you happen to not to see those minor details, these details might lead to severe complications. So these are just exercises of somebody who wanted to be a laparoscopic surgeon. So let's start. So the topic that I'm going to discuss is about minimally invasive surgery, or what we call laparoscopic surgery. So what are my objectives? So I'll just be discussing a bit of these topics. So this is the usual laparotomy incision. No? Before we had laparoscopic surgery, laparotomy is making incision over the abdominal cavity, over the organ you want to remove. So this is an exploratory laparotomy. And the other one on your right is your thoracoabdominal incision. So this is the usual open cholecystectomy. You make a right upper quadrant subcostal incision. No? So you expose the area of the gallbladder and you remove the gallbladder through this incision. This is the incision in which you can see you have transected all the layers of the abdominal wall. So imagine the pain that will inflict the patient after the surgery. So this is an incisional hernia. So this is not a pig, no, this is a human being. You see the extent of the injury. You can see on your right. This is the patient after dissection, before closure. And this is the patient after completing the surgery. So we have a very long transverse incision and a vertical incision to address the problem of this patient. This is another patient who had a bilateral hernia, so an inguinal hernia done before and had a recurrence. So you can see the reoperation, a transverse incision from the lower abdomen. This is a ruptured appendicitis. You can see the size of the appendix. It's smaller than the finger of the surgeon. But you need to make a very long incision just to clean the entire peritoneal cavity. So even if this is a small appendix, the cleaning of the peritoneal cavity needs a longer and wider incision. These are the usual surgical instruments that we use for open surgery. So you can see the retractors that are being used. It has to fit into your incision to expose the surgical field. This was the first experimental laparoscopy done by Dr. Kelling in dogs. He performed it in dogs during that time, in 1901. The first human laparoscopy was performed by Jacobius in 1910, and the term laparoscopy and thoracoscopy was introduced. He actually made this laparoscopy for diagnostic purposes. So in 1910, the reason for doing laparoscopy or thoracoscopy, if you look at the thoracic cavity, is merely for diagnostic purposes. In 1929, Kalk advocated a second puncture site. So meaning this time he wanted to use laparoscopy for therapeutic purposes. He devised certain lenses and introduced pneumoperitoneum, meaning you introduce air in the peritoneal cavity, and different types of lenses to make things clearer. Fiber optic technology was introduced in the 1950s, and the participation of another surgeon as surgical assistant. So the multi-puncture surgery was born, and the development of a better video camera system. The most important development was the introduction of the insufflator. The insufflator is the machine that pumps air or carbon dioxide into the peritoneal cavity. So it creates a working space for the surgeon. This is Dr. Philip Murray. He was the first to perform cholecystectomy, laparoscopic cholecystectomy in humans. No? So this is in 1987. So what is minimally invasive surgery? So minimally invasive surgery is the use of a high-tech imaging system. The surgical instruments are made smaller and longer and aims to minimize the trauma of surgical exposure. So studies have shown that laparoscopic approach compared to open surgery has a decrease in the immune response and metabolic response. So you are familiar with the response to injuries, and the trauma that you inflict will produce a significant or a proportional effect, or even more, to the trauma that you inflict the body. So in laparoscopy, since you are just operating on small incisions, the effect to the body is very minimal. It has been shown that there is rapid equilibration of the stress mediators. There's less immune response or immune suppression. There's more rapid normalization of the cytokine levels. So minimally invasive surgery does not only is not only used in surgery. It crosses the major surgical or clinical departments, from general surgery, neurosurgery, gynecology, thoracic surgery, uro, development of a better. The insufflator is the machine that pumps air or carbon dioxide into the peritoneal cavity. So it creates a working space for the surgeon. This is Dr. Philip Murray. He was the first to perform cholecystectomy, laparoscopic cholecystectomy in humans. So this is in 1987. So what is minimally invasive surgery? So minimally invasive surgery is the use of a high-tech imaging system. The surgical instruments are made smaller and longer and aims to minimize the trauma of surgical exposure. So studies have shown that laparoscopic approach compared to open surgery has a decrease in the immune response and metabolic response. So you are familiar with the response to injuries, and the trauma that you inflict will produce a significant or a proportional effect, or even more, to the trauma that you inflict the body. So in laparoscopy, since you are just operating on small incisions, the effect to the body is very minimal. It has been shown that there is rapid equilibration of the stress mediators. There's less immune response or immune suppression. There's more rapid normalization of the cytokine levels. So minimally invasive surgery does not only is not only used in surgery. It crosses the major surgical or clinical departments, from general surgery, neurosurgery, gynecology, thoracic surgery, uro. All the subspecialty uses this minimally invasive surgery and performing major operations through those small incisions. Okay. So thoracoscopy, or what we call video-assisted thoracic surgery, is another group of individuals. These are the thoracic surgeons performing minimally invasive surgery in the thorax. The problem here is you have a cage, the rib cage. No? So this or the bone space because that space is fixed. So what you do is you collapse the lungs. No? So you use double lumen endotracheal tube to collapse the lungs that you need to operate, and you surgery is surgery in rib cage. Extracavitary minimally invasive surgery. It means have a working space. So the movement in the thoracic cavity is different from that of the abdominal cavity because of this rib cage. Extracavitary minimally invasive surgery. It means you operate on areas that usually do not have a space, just like the abdomen and the thoracic cavity. Extracavitary minimally invasive surgery is a special procedure in which the surgeon makes or develops his working space. So an example of this are the totally extraperitoneal inguinal hernia repair. So the repair of inguinal hernia, there are two types, no? The TEP and the TAPP. The TAPP is transabdominal, so you have a working space. Endoscopic thyroid surgery. So imagine working in the neck without a space. So you need to create that space. Endoscopic mastectomy, endoscopic retroperitoneal nephrectomy, and the video-assisted retroperitoneal debridement. So this is actually, or the VARD, no? This is a procedure done for pancreatic necrosis. So you do not enter the abdomen. You create a working space in areas which there are usually no cavities. So endoscopic thyroid surgery is the best example of an extracavitary minimally invasive surgery. So this is the position of the patient. So the thyroid problem is on the right side. That's why you stay on the right side of the patient. So you insert the same instrument you use for laparoscopy. You just make a space in that subcutaneous area. So this is the area where you access the right thyroid gland, from the right axillary area. You create a space, you separate the fats from the muscle. This is now the view outside. This is where you have created the space, and you can see the transillumination outside. This is the area now of the thyroid gland on the right. The muscle that you see is the sternocleidomastoid. So this is the gland. You can see the bulging of the gland there. So the surgery actually creates a space over the thyroid gland. So what is the advantage of this? You don't have any scar over your neck after the surgery. So it's an extracavitary type of minimally invasive surgery. So anesthesia. Anesthesia in laparoscopic surgery actually is almost the same in any open surgery. But here, you actually watch over the effects of your absorbed carbon dioxide. So carbon dioxide will be dissolved in the blood, and it will produce metabolic acidosis in excess. No, that's why the anesthesiologists are very are considering acidosis every time you are in laparoscopic surgery. Also, you have to maintain that your lungs has a good ventilation and perfusion function, because CO2 is excreted by way of the lungs. So if you have a poor for pulmonary function, then you have CO2 retention. So this is the MIS team. You have the lead surgeon, the cameraman besides the surgeon, the first assist, opposite the surgeon, your anesthesiologist, your OR nurse, and your laparoscopic or your minimally invasive dedicated lap nurses. So this is in 2000 and 2003. This is 2019. So you can see the transformation of the operating room, and also better instrumentation, better equipment. So minimally invasive surgery was initially termed as band-aid surgery, keyhole surgery, buttonhole surgery, minimal access endoscopic or pinhole surgery. It is because of the small incision. But now, to make it a uniform, we term it minimally invasive surgery. So what are the advantages? So improved diagnosis, less tissue disruption. Because of that, you have less wound infection, less post-operative pain, and less chance of adhesions, especially in female patients. Every time you do a laparotomy in a female patient who is in her childbearing years, will actually have some form of pelvic adhesions. Cosmetically, you have better outcome, less surgery-associated complications. So most open surgery would complicate with atelectasis or pneumonia because of the long bed. The patients are bedridden. Sometimes patients developing deep vein thrombosis because of late ambulation. So for laparoscopy, all of these are actually lessened. You have early ambulation, early return to work, early feeding. So these are examples of laparoscopic surgery in an infected abdomen. So usually this is from a ruptured appendicitis. So from the initial picture I've shown you a while ago, you need to make a very long incision. So for laparoscopy, you have a 5 millimeter incision, at least 2 5 millimeter incisions, and the camera, 1 centimeter. So we have 3 ports. So through laparoscopy, you can wash the entire peritoneal cavity without making a big incision. And then you remove the appendix. So the advantage of this is you do not touch the bowels, you do not inflict more inflammatory process. And even if you have this type of peritonitis, you expect your patient to ambulate in the earliest is second to third day, better than open surgery. So post-operatively, most patients do not require intravenous narcotic medications. So most of the time, you see the patients ambulating few hours after surgery without even feeling any pain. So most of the time, you have at least grade 2 or 4/10 of pain scale, and you can actually expect less nausea and vomiting because of uh, probably with the anesthetic that are being used nowadays, and early feeding. So in open surgery, you wait for around 3 to 5 days before the patient would have a regular bowel movement or at least passes flatus. In laparoscopy, it's earlier. In less than 24 hours, you have already flatus. Therefore, you can initiate early feeding. Disadvantages. So the major disadvantage, they say it's more expensive. The potential for major complications in inexperienced hands, the loss of tactile feedback because you're not touching the tissues directly, you use instruments, difficult and complicated cases, and therefore you expect longer operative time in those cases. The expense is actually almost the same as that in open surgery, because in open surgery, you stay in the hospital for an additional of 2 to 3 days. So the cost that you spend for staying in the hospital is actually better, because you already are being discharged in laparoscopy earlier than open surgeries. So today, virtually no abdominal surgery is accepted from laparoscopic technique. So meaning anything that is inside the abdomen or anything that you want to remove could be performed laparoscopically. Patient selection. It's usually same in open surgery. If the patient is a candidate for open surgery, you can use laparoscopy as long as the expertise is there. The goal is to perform the procedure in a manner not significantly different from that of the standard technique, but without opening the peritoneal cavity. So you save the patient from much pain, also from complications of infection and incisional hernias. Laparotomy has a higher chance of incisional hernias. And in a usual exploratory laparotomy incision, you expect 30% of these patients will develop incisional hernia in the future. So in laparoscopy, you don't have that problem of incisional hernias. So the only absolute contraindication for laparoscopy is the inability to tolerate general anesthesia. So all patients undergoing laparoscopy are in general anesthesia. There are some institutions, or there are some surgeons who are actually going into research doing spinal surgery, spinal anesthesia, or epidural anesthesia in lower pelvic surgeries like inguinal hernia repair. But still, the problem will be the patient is restless during the procedure. So most of the time, general anesthesia is the one we use for laparoscopic surgery. Relative contraindications. So training of the surgeon is very important because you need a lot of manipulation, and you need to observe your patient, check your patient, and at the same time, you worry about the procedure and the possible complications. Carcinomatosis, pregnancy, previous surgeries, and the rest. These are relative contraindications before. So meaning it is dependent, or it rests on the surgeon or the expertise of the surgeon. So the difficulty would expectedly be increased in situations like obesity and patients with previous surgeries. So these are actually contraindicated before, but as you all know that now obesity is being treated with laparoscopic surgery, particularly the laparoscopic sleeve gastrectomy. So you expect difficult surgeries in this patient. Surgical technique. So you need to access, create pneumoperitoneum, do a initial diagnostic laparoscopy, insert your trocars for access of your instruments, you position your patient, extended laparoscopy. So you have to do all of those things before you start the operation. Unlike in open surgery, just cut the abdomen and proceed with the surgery. So access. Access is the most important part of the technique. It is during this time that more than 50% of injuries happen. So there are different techniques in laparoscopic access, but we in FEU uses the open Hassan technique. So you use trocars after the access. Now you use the trocars, you call the Hassan trocar or the primary trocar. You insert through the umbilicus. So there are two methods of access, direct puncture and direct peritoneal access. So direct puncture is literally inserting a needle directly into the peritoneal cavity. So this is a closed technique, a blind procedure. So obviously, if you are not familiar with the procedure, you can perforate the bowel, or even you can injure the great vessels over that puncture area. This is the Hassan technique, or the open Hassan technique, or we call the open technique. This is the standard approach that we use, in which you make an incision at the umbilicus, at the inferior border. It is the thinnest part of the abdominal wall, and usually the scar is concealed after the surgery. So you make and dissect the fats, and then you grab your, okay, there's your fascia now. You grab your fascia or the umbilical ring, and then you cut that fascia vertically. Okay, so once you cut that fascia, you are now left with the peritoneum. So the peritoneum, you just dissect it bluntly. So you use your forceps, then you are inside the peritoneal cavity. So as you can see, it's a direct visualization. You minimize the injuries that you can encounter in a close or a blind technique. Then you put the anchor and insert your trocar, the first trocar, in that incision you call the Hassan trocar. Okay? So after that, so these are examples of Hassan trocars. They come in metal or plastic trocars. You can see the tip, it's blunt. So you minimize injuries to the bowels. On the left lower image, you see a secondary trocar. These trocars are pointed, conical or pyramidal type. No? So meaning there's a point. So when you insert these trocars, you have to visualize them directly. No? So those secondary trocars are inserted after insufflation. So they make different types of defects, 5 millimeter, 10 millimeter fascial defects. So usually a 5 millimeter fascial defect after the procedure, you don't need to close them. They will close eventually. 10 millimeter trocars off the midline and above the umbilicus do not require repairs as well. So you only repair 10 millimeter trocars that are located through the umbilicus, along the midline, or below the umbilicus. So remember that. So open technique is safer. So we use open technique in all our surgical access. As you can see here, if you happen to puncture the vessels or the bowels, can lead to devastating injuries. So these are the umbilical trocars inserted. This is the access that you made. So this should be closed primarily after the procedure. All incisions along the midline and below the umbilicus. So you need to close them. The rest, you don't need to close them. So port placement. In laparoscopy, triangulation is very important. Okay? There should be at least a 10 centimeter distance between trocars, 10 to 15 centimeters. The telescope should be placed in between those trocars to give you a good triangulation. So this is the basic principle of laparoscopy. If you break this principle, you'll have difficulty in performing the procedure. Single incision laparoscopic surgery. So as you can see, the port is single, meaning you access it through the umbilicus and you insert all your instruments in one area, which is the umbilicus. That is why it is called single incision or single access laparoscopic surgery. So what is the problem here? You break the principle of triangulation. So there are surgeons who perform this procedure because some patients do not want any scar, especially female patients. So the problem will be on the surgeon because it is really difficult to perform a surgery with all your instruments located in one area, as shown in this picture. Hand-assisted laparoscopic surgery is you insert your hand in the abdomen during the operation. So usually you do this for advanced cases like colon surgery, pancreatic surgery, sometimes gastric surgeries. So any surgery that you had difficulty in using your instruments to perform the procedure. So you insert one hand, the non-dominant hand of the surgeon goes inside the abdomen, and the rest of the port are still working. So you make a small incision also for those ports. Another is natural orifice transluminal endoscopic surgery access. So this is what we call notes, in which the operator would access not the usual area, which is the umbilicus. Some use the oral cavity through the stomach. Some use the vagina, so transvaginal approach, in which you enter at the posterior fornix into the peritoneal cavity. So you can imagine how notes is being done. So most of the time you use flexible scopes. So it makes the procedure even difficult because you have a flexible scope, and doing the procedure through the tip of that flexible scope. And probably the problem here will be the control of the procedure. It's more difficult than the traditional laparoscopic approach. So pneumoperitoneum, we mentioned that you have to create a space, working space, for you to perform the procedure. There are two ways: mechanical abdominal wall lifter and air insufflation, or you introduce gas. So this is the mechanical approach, in which you have an abdominal lifter. Literally, you lift the abdominal wall and create a working space. So the problem here is there is limited space in the peritoneal cavity because all of the bowels will actually go towards the midline. So you lift the abdominal wall, you have a certain the effect of the lifting of that abdominal wall. You also compress the bowels towards the midline. And there is the advantage of this is there is no physiologic derangement in the body, just like the pneumoperitoneum and the absorbed carbon dioxide. So this is the picture or image of an abdominal lifter. There's pinching in of the lateral wall. So you have more pain after the surgery because there's a huge metal that is being inserted in the umbilicus to lift the entire abdominal wall. For pneumoperitoneum, several gases have been used before. One is nitrogen. So the problem is it's poorly soluble in the blood, and there's more pain after surgery because the nitrogen stays inside the peritoneal cavity. It's not absorbed. Nitrous oxide is a gas. So the problem here is its safety in pregnant patients, and if it is really not combustible. Nitrous oxide is also known as the laughing gas. So if it happens during surgery that the gas leaks in the operating theater, so all of the team members will end up laughing. Carbon dioxide is the most commonly used gas for pneumoperitoneum. Why? Because it is rapidly absorbed in the peritoneal cavity. It does not support combustion. It's cheaper and readily available. So this is the standard gas that we use up to this time. The problem with pneumoperitoneum is you create a pressure, a certain pressure in the peritoneal cavity, and there is a gas that is absorbed through your peritoneum and goes into the blood circulation, causing changes, the physiologic changes. So one is local effect and systemic effects. Local effect is that when you distend the peritoneal cavity, you also exert pressure on the diaphragm because of the elevation of the diaphragm. Because of that, you compress your lungs. And because of the compression or the pressure in the peritoneal cavity, your major veins will also be compressed. And therefore, sometimes it alters the venous return. There is less blood returning to the heart. Systemic effects are the absorbed CO2. So you have hypercarbia, you have acidosis. So with that absorbed CO2, there is a direct effect in your myocardium. There is an inhibitory effect in your myocardium. Therefore, CO2 insufflation is actually being used for patients with cardiac surgery, a cardiac problem at a lower pressure. So the usual pressure, we lower it down for patients with cardiac problems. So this is the problem when you have increased intra-abdominal pressure, you compress the lungs. So the problem here is it produces some sort of basal atelectasis. So after the surgery, patients within the first 24 hours sometimes develops fever. So this is due to the basal atelectasis during the pneumoperitoneum. So most patients after the surgery, you tell them to have deep breathing exercises just to re-expand those atelectatic lung bases. So increased intra-abdominal pressure, as I've said, would actually affect the heart. So for these patients, you have to decrease the flow rate less than 5 liters per minute and the pressure to 8 millimeters mercury. So the pressure that we use is around 10 to 15 millimeters mercury. If the pressure goes beyond 25 millimeters mercury, you have a great circulatory problem. The problem will be a tremendous decrease in the venous return, and the patient may actually die of cardiac arrest because of inadequate circulating volume. Acidosis actually would also give you a problem in patients with diabetes because it will aggravate the problem of diabetes mellitus, especially in the kidneys. So initially, if you are doing laparoscopy, in the kidney, you have a transient increase in the renal flow. But later on, because of the acidosis, you have decreased renal flow that will result to decrease in the urinary output. So these are the effects of increased intra-abdominal pressure. So because of the increased pressure, have increased vascular resistance. Okay, so this is the effect of the decrease in the venous return, decrease in the cardiac output, and it may result also to deep vein thrombosis. So in some patients, for prolonged surgery, especially advanced laparoscopic surgery, you have to place pneumatic compression boots to your patients to compress your legs so as to prevent deep vein thrombosis in these patients. So these are the different patient positioning. So usually patients are in supine position and the surgeon can stand on the left or right or even in between the legs. You call it the French position, or the one on your right, the patients on lateral decubitus for retroperitoneal approaches. So most of the time, we use the supine position. Trendelenburg position is head down. No? Fowler's position is head up. So usually in a Trendelenburg position, it causes further displacement of the diaphragm and further strain on top of the effects of pneumoperitoneum. So in patients with cardiac problem, again, we minimize excessive Trendelenburg position. So usually we support the patient by putting her down on a slight Trendelenburg and monitor the patient if there's a problem with the cardiac output or even if the patient develops arrhythmia. So if that happens, you may want to do the surgery in a just level position without putting the patient on a Trendelenburg position. So this is a Fowler's position. It's better physiologically for the patient. So this is the standard pressure that we use, 10 to 15 millimeters mercury. So most of the time, we maintain the pressure around 12 millimeters mercury. So again, for patients with a cardiac problem, you put the pressure to 8. So what happens during initial pneumoperitoneum? Again, when you infuse air into the peritoneal cavity, the insufflator, which is around, it can give you around 40 to 50 liters per minute. Your abdomen can only accommodate around 4 to 5 liters of air. So if you infuse 40 liters per minute, there is sudden stretching of the peritoneum. There's sudden distension of the abdominal cavity. It will give you a reflex, or the vagal reflex would give you a bradycardia. So a reflex bradycardia that happens after insufflation causes arrhythmia, the sinus bradycardia. So if this happens during surgery, stop the insufflation, release the air, check your patient. If your patient is recovering from the bradycardia, stabilize the patient, and again, reintroduce the air at a lower flow rate, probably around 5 liters per minute, and using a lower pressure. So once a patient is stabilized using this technique, then you can now increase your insufflation rate. So why do you need a high insufflation rate? So because during surgery, there are smokes, there are plumes that are developed in the peritoneal cavity, and you want them to have a clearer image of the intra-abdominal cavity. You leak the air, you remove the air by opening your trocar. So if your pneumoperitoneum flow rate is low, you cannot actually create a working space. So you need a faster flow rate around 30 liters per minute to maintain your working space. So anesthesia-related problems, as I've said, the absorbed CO2, and usually the problem of open surgery like the insensible fluid losses because of the open cavity. So in laparoscopic surgery, you don't have much insensible fluid loss. So are laparoscopic procedures more risky than the open counterpart after knowing all these problems? So I think the answer is still no, because you just need to learn, you just need to know the effects and know the problems that you may encounter so as to prepare yourself during surgery. So experience is very important. Limitations. You work in a two-dimensional view with restricted vision. There's no tight tactile feedback. And actually, there is a learning curve that you need to know before you can perform a certain procedure. Just like a laparoscopic cholecystectomy, you at least need 10 assisted and 10 performed surgeries before you can actually perform surgery on your own. So if you want to learn other organs, you still need to pass this learning curve, in which after you have performed a certain number, you can do laparoscopic procedure on your own. So the field of vision may be restricted in laparoscopy, but it is magnified. So your image is actually magnified in laparoscopy compared to your open surgery. So this is the very good advantage of laparoscopy, because you can see the anatomy clearly because they are magnified. Robotic surgery is another approach in doing laparoscopic surgery. So the advantage robotic surgery over a traditional laparoscopy is the improved manual dexterity and the ergonomics. So meaning you have a better posture, you can do anything because the robotic arm can rotate 360 degrees in a different position. So the only problem with this is it's really expensive. And the one advantage is you can do remote surgery, meaning if you are not in the operating theater, you're somewhere else, you can control the robot. So this is the robot, the Da Vinci robot, and you have the same instruments that you use for laparoscopy, but now they have a robotized arm. You know? This is the first robotic surgery performed in the world. It was in 2001, and it was performed by Dr. Maresco. You can see that he performed the procedure from France, and the patient is in New York. So it's quite distance, no? That the surgeon is controlling the procedure from his operating theater at Strasbourg, France. This is Joseph, Dr. Moresco, and you can see he's operating with just plain clothes. No need to do scrubbing because you're not directly in contact with the patient. The team that are in the operating room in New York are the ones scrubbed in. So there is a bedside surgeon. So meaning if anything happens or if the patient needs to be opened up, then the bedside surgeon will open the patient. So this procedure was done successfully in 2001, and it is a laparoscopic cholecystectomy. Endoluminal or endovascular surgery are actually now being done minimally invasive. So there are certain stent placement or recanalization using this minimally invasive technique. So some aneurysms, some problems with major vessels are not being done surgically. So notes, so just to show you how it's being done. So this is a transoral approach, cholecystectomy. Using an endoscope, you go into the mouth, out to the stomach, into the gallbladder area. So this is how endoscopists perform this procedure. So the key is adequate exposure. So when we say adequate exposure, we aim for a safe surgery. That's why in open surgery, they say bigger incision is safer and bigger incision for bigger surgeons. No, that was the saying before. But now, I think this adequate exposure was actually augmented by great images that we use in laparoscopy. This is the OR setup. So the surgeon stands opposite the image, opposite the organ that is being removed. Beside him is the cameraman and the assistant on the opposite side. This is the ideal operating theater in which all the equipment needed, the tower, are being hanged over the ceiling. So there's no clutter around the floor, so the surgeon can go around left side, right side, depending on the type of procedure that is being done. This is the standard video monitor. It's a high definition medical grade monitor used for laparoscopy. Resolution is very important in laparoscopy because you are dependent on what you see in your screen. So before, we actually use standard definition. Ito yung mga lumang TV that you see in your ancestral homes. the 4:3 ratio. You have very low resolution, black and white. No, so those are the monitors before. Then came the high definition systems. Then we have the full HD, the 4K resolution, all to improve the resolution of your images during laparoscopy. So this is the usual old computer 4:3 ratio. And now we have the 16:9. It's a panoramic view and a clearer image of or clearer video that you see in your operating theater. So what are the difference of these two? So you can see here interlace and progressive scanning. Interlace scanning are the ones that you use for your 4:3 monitors. If you try to take a video or a picture of your old monitor, you can see horizontal lines. It is because interlace scanning is this way. While progressive scanning is, there is continuous projection of your image. That's why your eyes does not need to adjust to your progressive scan. It means what you see is what you get. So you have lesser eye strain, lesser vertigo, and a clearer image for the surgeon. So despite the proven advantage of laparoscopy, why are there still a lot of surgeons prefer open technique? It's because in laparoscopy, you have problems with depth perception. Now, the depth perception in laparoscopy is the main reason why some surgeons prefer open surgery. So you have to master how the image and how you process the image in two-dimensional into three-dimensional image. So are you familiar with spatial visions or visual using the spatial intelligence? No? So this spatial intelligence is the ability to draw accurate conclusions from observing in a three-dimensional environment. So meaning you need to learn how to perform laparoscopy compared to that in open surgery in which you have an open or you see the image in three dimensions and you can touch them. The feel and the sight of an open surgery must be transmuted to an open or laparoscopic approach. So you have to train. This is actually the greatest skill, because you are operating through a video camera system. You have to understand the depth of the field. So it is very important because if you miss something, if you miscalculate the structure, especially if it's a vessel, then it will be a disaster. This was actually resolved by using 3D laparoscopy. So 3D laparoscopy is like operating in open surgery, in which you have a three-dimensional image of what you see in the camera system. But you need to wear goggles that are used for three-dimensional images. So this is a laparoscope, and these are the parts. No? You are supposed to know this because laparoscopy is very dependent on the optics. You have the eyepiece, you have the light post, you have the light channel, you have the rod lens assembly, and you have the objective lens. Different types of laparoscopes actually have 0 degree and 30 degree. And you have the flexible scopes. The 30 degree or the angled scope is very important because it sees a wider range of images. Unlike a 0 degree, you can only see what is in front of you. For 30 degree or angled scope, you can see left and right, up and down, wider field of view compared to that 0 degree. And the best is a flexible scope because you can see the entire abdomen more than the 30-degree scope. So the rod lenses are very important because it will give you a better image if you use rod lenses compared to the biconvex lenses. These are the different camera heads. So these are you connect your scope to this camera head, and then you connect them to your video processors or your CCU. So these are now the high definition camera systems available. Light source is another important factor because light source is the ones that will illuminate the abdomen, and it should be as near as the sunlight. No? So it's around 580 Kelvin, and at least 250 watts because as the light passes through the cable, it decreases its intensity. So there are three types of camera bulbs. You have the halogen, the xenon, and the LED. The LED are the coldest, and they are the brightest, and usually longer half-life. See the half-life? It's 10 times that of a xenon. So it's 100 times. No? So usually when you use a LED, they say it's cold, but still it emits light. You expect some form of heat that is transmitted in your cable. So don't be meaning you have to be very careful on the cable because the tip of the cable is still hot in spite of the term coldest light. So when it touch a skin or drapes of your patient, it can burn that area. No? So this is the cable. It's a long cable, 1.5 meters, and the efficiency of the light is actually lost around 90%. So imagine 90% of the light is lost as it travels to the optics. So you need a really very strong wattage of light. So these are different instruments, hand instruments that you use. You have the insert, the shaft, and the handle. So they come in three pieces. There are different types of instruments: right angle, dolphin, Maryland. No, so these are the different dissectors that you use. Depends on the preference of the surgeon. They have different uses. So some are used for grasping, some are used for dissection, some are used only for manipulation. So these are the graspers. So you have serrated grasper. It is you have a better grasp of your tissue compared to those with fine graspers. So you have the hook, electrosurgical instrument, monopolar instrument to use for dissection. So they come in different sizes actually. So the question is if this different instrument really matters, no? The sizes matters. I think yes, no, because this is a needle instrument. It's a 3 millimeter instrument that you use percutaneously. So you can see they are flexible. So if you use this for complicated cases, you will have a problem. So they are only being used for uncomplicated cases because they are really flexible, and you cannot the force that you can apply to the tissues is very minimal, unlike the standard 5 millimeter instrument. But the advantage of this is because they are smaller, they inflict less pain post-operatively. So smaller incision, less pain to your patients. So these are different suction irrigation system. You have the different tips. You have blunt, no? You have fenestrated, you have the needle type. So they are used in different purposes. So what do you call this? So most would call this cautery or electrocautery. It's not electrocautery, no, because as you will see later, I will explain why it should not be called cautery. So now we go to another important aspect of minimally invasive surgery, which is electrosurgery. So electrosurgery actually was introduced years ago, but there are several development and advances in energy devices. Yet, despite their frequent use, they actually remain poorly understood. A lot of complications happen in the use of electrosurgical unit. So why? No. So the see one, do one principle, because when we are in the operating theater, no one will teach us what is this machine. So we call it cautery. No? Hindi pala siya cautery. So it is considered a dangerous weapon if it is not properly utilized. So the problem is you have a high current, high electrical energy that flows in your instrument and you don't know what it is and you just use it during surgery. Take note, the most common complication happen in laparoscopy is from trocar access. Electrosurgical complications are the second most common problems in laparoscopic surgery. So radiofrequency energy. Now, before we go there, let us see some terminologies. We usually term cauterize, burn in the operating theater, but actually should be called electrosurgical unit. It's electrosurgery. So we don't want to burn the tissues, but we want to vaporize, we want to cut, we want to coagulate the tissues. And in that way, we are not burning them because burning the tissue is damaging the tissue. So it has to be corrected. No? So these are the proper terms. So you remember these terms. Cautery is a passive transfer heat, meaning there's a heated object, you touch the tissue, you are cauterized. So that is cauterization. And that is not the principle in surgery because we do not have a heated object. We have an instrument that is functioning differently and producing an effect. And that is what you call electrosurgery. So this is the principle behind electrosurgery. So there are two currents, direct current and the indirect current. So direct current is what you see in your batteries. So this is a pen. This is electrocautery pen that we use to coagulate warts. So it uses direct current because it uses battery. The other one is the electrosurgical unit. So the electrosurgical unit uses indirect current. So from your plug, you plug this machine, which is the electrosurgical unit, and it transforms the electrical current into a radio frequency waves. So it's around 500,000 hertz that are being used in the operating theater. So these are the different frequency of waves that we use. The outlet is 60 hertz. So when you happen to plug and you get electrocuted, there's a twitch because the frequency is only 60 hertz. Electrosurgery uses 200 kilohertz to 3.3 megahertz, meaning you increase the frequency. That's why when you apply it to tissue, it does not have any electrocution because the frequency is higher. So this is indirect current used in electrosurgery. So there's alternate movements of the electrons and the protons. And that movement of 500,000 times produces the heat in the tissue. So the electrical current that is being transmitted to your tissue produces that effect in the tissues, producing your coagulation and your vaporization effects. So it's not the same as cautery. Okay, so these are the two differences of electrosurgery. There's heat because it uses direct current, and electrosurgery, there is current that passes to the tissue, and within the tissue, there's movement of electrons and protons that produces the effect. So that is the difference. So there's no Faradic effect using this radio frequency because it is higher radio frequency that we use. Unlike your current in your plug, it uses 60 hertz. So you do not have muscle twitching. The temperature that you need to coagulate a vessel is around 50 to 80 degrees. That's it. Beyond that, you have burns, you have cell death, and you have charring effects. So these are the different effects that you want. Vaporize, fulgurate. So you can see the application is different, and desiccation. So the different effects that you see is actually because of the different application and the different setting that you use. Okay, so this is what happens in monopolar system. So the current passes through the patient and returns to the machine. So there's a circuit. So anything that is within that circuit, there is electricity. That's why if the patient is actually wet, it can actually give you burns in the tissues or areas that are not usually in the operating field. That's why you have to be very careful with this. So this is activation time. The longer that you activate the system, more heat is being produced and more tissues are getting burned. So the temperature is only 50 to 80 degrees. So 3-second intermittent activation. If you try to activate the pencil for more than that, you have a higher temperature. It can go up to 100 to 120 degrees, and it causes a lot of injuries. So advantage of monopolar, you can dissect the tissues, and you can have a greater penetration. And the disadvantage is that you have larger tissue of injury and requires a dispersive electrode. So you have a circuit compared. So this is an example of a monopolar system. So as I've said, it's a circuit. Therefore, the current flows through the patient as well. This is bipolar instrument in which the energy is confined only where you apply the instrument. So there is no need for a dispersive electrode, and the current does not pass through the patient. It's only concentrated at the tip of the instrument like this. So nandyan lang yung current between the two edge of that instrument. Okay. So this is the effect of bipolar system. So the two instruments are have the current. It does not pass through the patient. This is the effect to the tissue. This is the advanced bipolar system. Okay, so that is the advanced bipolar system, in which is being used now to coagulate vessels. So these are examples. No? This is a liver surgery in which if you use monopolar instrument, you will encounter a lot of bleeding. So with advanced bipolar system, you minimize the bleeding. Another is ultrasonic shears. So these are mechanical waves. You can see the movement of that jaw. It's a mechanical movement that produces the heat. Okay, so there is back and forth movement around 350,000 times and produces the heat. So there's no radio frequency. There's no radio frequency energy here. Okay, so it's a mechanical energy in which there's a forward and backward movement of that instrument, of that metal, producing the heat. So this is an example of that, no, the harmonic scalpel. So applications of laparoscopic surgery. So laparoscopic cholecystectomy. You are familiar with this. This is the most common procedure that is being done. Okay. Common bile duct exploration. So meaning you remove the stone that is located in the common bile duct using basket. So this is endoscopic procedure. You catch that stone using a basket and you retrieve it there. Okay, so those are endoscopic procedures combined with laparoscopic surgery. This is liver resection. So still very minimal bleeding with the use of this advanced bipolar system. Complicated appendicitis. So as I've said, we use this more commonly now because complicated appendix would have a longer recovery if you do it in open surgery. But you need advanced instrumentation for this. So you can see the necrotic tissues in the area of the cecum. And you put it in a pouch before you extract it from the umbilicus. This will limit surgical site infection in your umbilicus. So this gastric surgery. So gastric surgery uses staplers to close, transect the stomach. And also we use staplers to re-anastomose the stomach. So this is pancreatic surgery or the Whipple surgery. So it's also being done laparoscopically. And using this technology, you encounter lesser or minimal bleeding compared to open surgery. And the advantage of the objects are magnified. So you can have a clearer image, better anatomical identification. So this is a type of complicated hernia. So multiple hernias in one. So you have a lot of hernias that are being done, but this is a complex hernia. Ventral hernias. So these are the results of incisional hernias. The abdomen after a laparotomy, you can expect ventral hernias or incisional hernias to happen. So you need to identify. So you just need to put a mesh, cover that defect, and tuck it. You put sutures or tuckers to fix that mesh so as it will not migrate in the peritoneal cavity and will be maintained in the area of the defect. This is a parastomal hernia. You can see the hernia on your left on a patient with a colostomy, and you cover it with mesh. Hand-assisted surgeries as well. So this is a pancreatic head tumor in which you need to remove that part of the tumor using your assisted by your hand, the hand-assisted surgery. There's the tumor. You can see the tumor there. So with hand-assisted surgery, the surgeon can feel the tumor or where the tumor is because it is within the pancreas. Okay, that's the tumor. That's it. So the tumor was removed using a hand-assisted approach. These are image-guided surgeries for the ICG, the indocyanine green guided surgery. You can see the gallbladder is colored green. So the advantage of this is that you have a better anatomy, you have a roadmap for a safe surgery. Unlike in usual laparoscopic surgery, your structures are all the same. They have the same colors, no? But with image-guided surgery, as you can see in your left lower image, the structures are colored. They are highlighted by the ICG dye. So you can actually distinguish which structures needs to be removed and which structures need to be avoided. So that's a common bile duct. Now, this is the gallbladder surgery in which the most common complication is bile duct injury. So this is the principle behind that ICG. Okay, so you inject a dye around 2 ml, 8 to 10 hours before the surgery. Okay, then in the blood stream, they will bind to proteins and they will be excreted in the bile and it goes to your bile duct. Okay, so it will go to your circulation. It attaches to your albumin and it's concentrated and excreted in your liver and it goes to your bile duct and your gallbladder. So during the procedure, your gallbladder is colored. So ibig sabihin, you have to dissect within the colored areas. And also, you can see so it uses different light. This is an infrared, no? The infrared image. You can see the bile duct, the gallbladder. So you have to avoid the bile duct because it should not be removed during cholecystectomy. Okay. So these are the other uses. It can be used for lymph node dissection, for sentinel node, for evaluating the anastomosis, and for locating the ureter, no, during a pelvic surgery. So you can see once you use that light, it illuminates. No, you can see the vital structures, and you can avoid them. Okay, so complications. As I've said, the complications are actually related to the procedure and to access and also the ESU. So this is the data showing you that the complications, 50% of them happens during access and pneumoperitoneum. Bleeding, bile leak, as you can see, is very rare, but the most devastating complication, bile duct injury. So these are trocar injuries. That's why you have to always watch or be inserted under direct visualization. The most life-threatening complication is intraoperative bleeding. Therefore, you have to be very careful and recognize and immediate laparotomy must be undertaken if you encounter bleeding during surgery. So laparoscopic cholecystectomy is the most commonly performed procedure, and the most common complication is bile duct injury. And the most common cause is misidentification of the bile duct as the cystic duct. So we have actually devised, or Dr. Strasberg actually introduced the critical view of safety, in which you have to identify the most important structures: the cystic duct, the cystic artery, and the cystic plate. So once you have identified these three structures, and only two structures entering the gallbladder, which is the artery and the duct, then you are ready to clip and transect the gallbladder. So these are the other procedures that are being done laparoscopically. So that is minimally invasive surgery, its principles, and overview. So seeing an image through your eyes, while vision is an image created by your heart. So as you have noticed, there was such an evolution or innovations. There are a lot of innovations that were done for minimally invasive surgery. and we are enjoying now. I think most of it now, because we have the best technology now in minimally invasive surgery. And the secret there is innovation. You as students will become doctors in the future, and as young doctors, you have to innovate, because innovation will yield to unscalable solutions, and innovation produces exponential changes, and this will have a proactive technology enabled care system. So meaning the future of medicine, the future of surgery is in your hands. That's why as young and talented students, you have to innovate. So I think that's all, and good morning, everyone.